Hi, class. Welcome back. It's Dr. Lindner. Now that we finished the introduction to what a plexus is, and we know that we have two plexi. Plexi is plural, plexus is singular. So we have two plexi in the neck. We have a cervical and brachial plexus. So that's what I'll cover in this video. And then I'll do another video on what we have in the lower back, which are two more plexi, a lumbar plexus and a sacral plexus. So the cervical plexus, remember the plexi they originate at the ventral rami. Remember the ventral rami are motor, the ventral rami are motor, whereas the dorsal rami are pretty much sensory. So the cervical plexus is from the ventral rami of C1 to C5, and it's going to supply mostly the going upwards to the head. Some of those fibers can come down to the beginning of the shoulder near the clavicle. And another important nerve that comes off the cervical plexus is this phrenic nerve. And the phrenic nerve originates from C3 to C5. So C3, C4, C5 help keep the diaphragm alive. So C3, C4, and 5 specifically go to the diaphragm. Now, you can have damage to the spinal cord above C3. If we think what's above C3, well, it would have to be C1 and C2, right? These two vertebrae in the neck. And this can cause respiratory arrest if there's damage above C3, right? Below C3 can damage the diaphragm and can halt breathing, of course. But damage above C3, meaning C1 and C2, can cause respiratory arrest primarily because the medulla oblongata is protected by C1 and C2, and this is the respiratory and the cardiac control center. So it is the heart and the lungs are controlled by C1 and C2. And this can cause respiratory arrest, especially in a condition that's known as SIDS, which stands for sudden infant death syndrome. Sudden infant death syndrome is commonly caused by birth trauma from birth, meaning there's an excessive amount of pulling on an infant's head and cervical spine that can damage and stretch C3, 4, and 5, kind of like a distraction of the spinal cord and the nerve roots. And when they rotate the baby's neck, especially the atlas, that can impede and interfere with nerve impulses going through the medulla oblongata that can impair heart and lung function. So when a baby's coming out and the obstetrician takes the baby's or infant's cervical spine and they rotate the head very strongly towards the shoulder and past the shoulder, they do that so the shoulders can align with the vaginal canal. But sometimes by doing that forcefully can create instability between the C1 and the C2 vertebra. And they call that atlantoaxial instability. There was a European physician, I believe his name was Gottfried Gutmann in Germany, and he autopsied 1,500 babies that died of SIDS. And what he found was a 100% correlation to atlantoaxial instability with children that died of sudden infant death syndrome, meaning the baby's heart and lungs just stopped working. typically when a baby is face down and the head is rotated, which cuts off the nerve supply even more where the medulla is because atlas creates rotation. So if you impede neurological function in that part of the brainstem, you can understand why heart and lung function can be compromised. That is SIDS, sudden infant death syndrome. When we take a closer look, now we can see here C3, here C4, here C5, right here is the phrenic nerve. So when you follow that, it comes off of C3, C4, and C5. That's the phrenic. That goes to the diaphragm. Okay. Now, let's take a look at the brachial plexus. This is the second group or cluster or braiding, if you would, of nerves that come from the neck. Now, one of the things that I want you to see here, right here, is that it originates in the neck. You can see from C5 to T1. So these are the nerve roots coming off of the cervical spine. And then what happens is you can see it goes under the clavicle. This group of nerves goes under the clavicle, and then the brachial plexus branches into what we call terminal branches. Axillary nerve, musculocutaneous nerve, radial nerve, median nerve. One, and I am missing 1, 2, 3. I think I am missing one. Let's see. Musculocutaneous, radial, medial. Maybe we got them all. 1, 2. Nope, I'm missing one. Where is it? The ulnar nerve. There it is. It's on this side. Okay, so there's 5 terminal branches of the brachial plexus. So there's 5 terminal branches. Those terminal branches are these nerves, 1, 2, 3, 4, and 5. Okay, now each of these nerves are going to go to a group of muscles. They're going to control motor function. And they go all the way down to the fingers. Now, one of the things to keep in mind is, think of the musculature of the neck. We have some muscles in here called the scalenes. Scalenus anterior, scalenus medius, and scalenus posterior, or maybe your professor called them scalenus anticus, medius, and posticus. There's just 3 of the scalene sisters. And the brachial plexus gets sandwiched between them. So if your neck muscles are in spasm, you can understand why they can pinch some of the branches of the brachial plexus. You know of another muscle that goes from the ribs, let's say somewhere up here, right to the coracoid process in this direction. There's a muscle that runs from the sternum and from the upper ribs right to that coracoid process, and we call that pec minor. So you can have a hypertonic or very, very tight chest muscle that within itself can compress the brachial plexus. And if whether it's the scalenes or whether it's the pecs, whether it's the clavicle, any of those structures can put pressure on the nerve, and that can cause symptoms into the hand. Just want to point that out to you. Okay. So the brachial plexus, as we just showed you in that picture, it comes from the ventral rami of C5 to T1. and it passes superior to the first rib, but it goes under the clavicle. We could see that right here, under the clavicle. So remember those terminal branches that I mentioned before? The axillary nerve goes to your deltoid muscle, and it goes to your teres minor. When you see a small m, typically it means minor. If you see a capital M, it typically means major. So the axillary nerve goes to the deltoid and teres minor. The musculocutaneous goes to your elbow flexors. So that would be your biceps brachii, and the other biggie is your brachialis. Your radial nerve, what's interesting about the radial nerve is whenever you think of radial, I want you to think of extension. The radial nerve extends anything that deals with shoulder extension, elbow extension, wrist extension, finger extension. Like more than 90% of the time, when there's a muscle that deals with extension, it's going to be innervated by the radial nerve. And then the median and ulnar nerve is primarily going to control the flexors of the wrist, the hand, the wrist and the fingers. And the majority of them will be median nerve. A few of them, very few, are going to get ulnar nerve. I can think of two that does ulnar nerve. There's the flexor carpi ulnaris, right? The ulnaris tells you it's ulnar nerve. And then you probably learned muscles that flex the digits. There was a flexor digitorum superficialis, and then there was a flexor digitorum profundus, which is deeper. So the flexor digitorum profundus goes to digits 2, 3, 4, and 5. And the ones that go to digits 4 and 5 are going to get ulnar nerve. Everything else is going to be median nerve. So in terms of wrist flexors and finger flexors, median nerve gets pretty much all of them, but there's 1.5 muscles that get ulnar nerve innervation. The one full muscle is flexor carpi ulnaris, and the half of a muscle is flexor digitorum profundus. What do I mean by half? I mean, if you look at these 4 fingers and we take half of them, not digits 2 and 3, but digits 4 and 5, those will have ulnar nerve because it makes sense. They're on the ulnar side. Okay. So here's a closer look at that brachial plexus. You can see they go from C5 to T1, and there's different aspects or components of a brachial plexus. For our purposes, I don't need you to understand that there's divisions and trunks and cords. If you're getting into more advanced neurology, if you're getting into manual medicine or physical therapy eventually, chiropractic, then you will need to know all of these components to it. For now, I just want you to know what roots they are, C5 to T1, and then the terminal branches, which we went over before. Those terminal branches being the everything that you see here in red, pretty much. The musculocutaneous, the axillary, the radial, the ulnar, and we are missing one, musculocutaneous. Where is the, there it is, there's the median. So those 5, musculocutaneous, axillary, median, radial, and ulnar nerves. Those are the terminal branches. Now, what I will discuss, I'll take a pause here. When I come back, I will introduce some of the clinical conditions that are involved with brachial plexus irritations and impingements.